It's okay. So I'm a psychiatrist and I work in the States, in the middle of the country, in Iowa, in a big academic medical center. And I'm the president of an organization called the American Association of Community Psychiatrists. And we have a lot of interests, but one of our interests is in workforce and how to best deploy the very scarce mental health resources most effectively and efficiently. And I'm also going to put a plug in for, I think I'm supposed to do a little workshop this afternoon on what my real passion is in terms of communication. I don't know how many of you know about motivational interviewing, but that's another real interest that I have, and so I'm going to be talking about that a little later. I think it's scheduled for this afternoon. So, and are there any psychiatrists in the room? You're a psychiatrist from the Hamburg area, correct? And everybody else is a different kind of mental health. Is everybody here related to mental health in some way? Yes? Medical student? Great. From where?
Saudi Arabia.
Lovely. And you are?
I'm master's level counseling in psychology.
Okay, from where?
From the United States, but I work with the Department of Defense schools in Germany.
Oh,
America,
interesting.
So I work with America.
Okay.
Yeah.
And we talked already, and you guys, what do you do?
I'm an MD, but I work only in psychiatry.
Oh.
So education, mostly research.
Really? Where?
At Dalhousie University, Halifax in Canada. Halifax,
Lovely.
Nova Scotia,
Okay.
Canada.
Okay.
I'm a research coordinator, and I work
Okay.
with doctors.
You guys are a pair.
We're a pair.
Okay. All right.
I'm Rita Fisher and I'm a psychologist from South Africa,
Okay.
and I'm very interested in the community psychiatry or community psychology area because we also have very limited staff.
Very what?
Limited staff.
Yes. I think that's very common. Yeah. So, okay. And you want to say?
I'm a clinical psychologist
Yeah.
and I work in a provincial psychiatric hospital in Manitoba,
Yeah.
Canada.
Okay. And we've already talked? Yeah. Okay. All right. I'm going to try to go through this fairly rapidly and give you a little bit of a sense of the mental health workforce, at least in the States. The bottom line is that there's a very significant shortage, and we'll talk a little bit about the factors that are driving that shortage. And then strategies. And this is where it gets interesting for me, because I think the way that we practice the way that we use mental health services today is going to be very different than the way we're going to be using them in the future. And a lot of that is going to be driven by the gap between the need and the available resources. We're going to have to think differently about how we provide services. And then I'm very interested when I go around and have the opportunity to talk in different countries and cultures about how other cultures are responding to these kinds of issues. So I don't know if there'll be time to discuss it, but maybe even in the breaks we can talk about that. So this is a big story in the U.S. It's widely recognized. These are just some recent, large newspapers talking about the shortage of psychiatrists, at least in the U.S. It's gotten quite a bit of attention over the last several years. And the best data on it actually came about 6 or 7 years ago. In the U.S., the states are divided into regions called counties. There are about 3,500 counties in the U.S. And there was an effort to estimate the gap between perceived need and mental health service capacity. And it was quite striking, especially for what they called prescribers. So these were either psychiatrists or any kind of psychiatric extender, whether that be a nurse practitioner, which is something we use in the States, or a physician assistant, or even primary care docs who were seeing a lot of patients with psychiatric needs. And the bottom line was that over 3/4 of all counties actually had a severe shortage. That is, the estimate was that less than half their need was being met. So almost over 3/4 of all of the U.S., there's an estimate that less than half of the psychiatric need is being met, which is pretty dramatic. Almost all had some unmet need. So they actually estimated this number, and it was interesting because I was talking to Dr. Kouros, is that how you pronounce his name? The organizer? And he was telling me that there are 3,000 psychiatrists in Greece, and I think he told me the population of Greece is 11 million. Does that sound right? That actually is 27 per 100,000. So amazingly, you guys are on the mark for the estimate of the need. In the U.S., that would mean there'd have to be about 78,000 psychiatrists for a population of 300 million. So how many do we have? How many should we expect in the future? And this is just an overview, especially since this is a mixed audience. I don't know if you can really read this, but if we think about the mental health workforce, at least in the U.S., we have clinical social workers. That's our most common. And these are, by the way, three different ways to estimate these numbers. They're widely variable estimates. But we have a lot of clinical social workers. The next most common is clinical psychologists. We have marriage and family therapists. Psychiatrists are the second to the last there, with estimates ranging here from about 40,000 down to about 25,000. And I said you'd need 78 to make that estimate. And then advanced registered psychiatric nurses. Yes.
LPCs.
What is an LPC?
Licensed professional counselors, the master's level or post-master's.
Probably, I don't know where they would go, and I'm not sure why they were not included in this, to be perfectly honest. Do you have an estimate of how many there are?
I don't.
Yeah.
But, I just know that some of them are MFTs,
Yeah.
but
Yeah.
clinical psychologist requires a doctoral.
Right,
So
right.
we're talking about the master's level, like clinical.
Yeah. I'm not exactly sure how they're categorized. It's a good question because, but they provide a lot of the workforce actually, so that's an important one. This is a little bit of a better estimate, I think, and it's a more optimistic estimate. I think these are the best numbers, at least in psychiatrists, about 45,000. And just to give you a sense of where that sits, at least in the U.S. relative to other docs, so you can see there about, in this estimate, which is a pretty good one, about 45,000 psychiatrists compared to over 100,000 internal medicine and family practice docs, pediatricians, OBGYNs, anesthesiologists. Now, interestingly, in the U.S. at least, the number of physicians has really increased linearly over the last 4 or 5 decades. But in psychiatrists, including international medical or foreign medical graduates, what you can see is that that increase has not kept pace. When we add child psychiatrists, it's a little better, child psychiatrists in red. But basically, the percentages of psychiatrists relative to other physicians is gradually decreasing. And part of it is that our trainee workforce has not been growing. So it is essentially flattened out. The number of people that we're training has kind of flattened out over the last several decades. This, in some ways, is the most important slide and the scariest slide. So if there's one statistic to remember about the psychiatric workforce, 55% of all American psychiatrists are over the age of 55 and are going to be retiring within the next 10 or 15 years. And that compares, if you ask that same metric, what percentage of internal medicine doctors are over the age of 55, it's about 40%. It's very consistent across all other subspecialties, about 40%. Psychiatrists are aging out, okay? And meanwhile, demand for psychiatric services is another topic, but there's every reason to believe that that demand is going to increase over time. I'll talk a little bit about why. So basically, we already have a significant gap, and we expect that gap to increase, and there's absolutely no reason to expect that the supply, at least of this part, the psychiatry part, is going to increase. In fact, there's pretty good reason to believe that it's going to decrease. Now, in my little home state, it's a particularly bad place. We have actually 8 per 100,000, so that's about a third of what the estimated need is. And a particular shortage of child psychiatrists. We have a total of 30 in the state. And this is a common problem. This is the county map. This is the county that I live in. So most of our psychiatrists work in the same building that I work in. So not only do we have very few, but they tend to be geographically located in the same place. So about half of all the state psychiatrists are in 2 counties, a quarter, and about half are in 4 counties. So that's a common problem. So we would need to double our current number of psychiatrists to reach the national average and nearly triple the number to meet a conservative estimate of expected need. The bottom line is that's not going to happen. Okay, it's not going to happen where I live, and I doubt it's going to happen in many other places. Indeed, I think we're facing a further decline. One way to actually quantify this and make it real is we have literally unfilled funded positions. So lots of places, hospitals, existing practices, where someone has left and they can't find someone to take that job. Not a theoretical need, but a practical need. So we have, most recently, 77 unfilled positions, and a total of 238 people could fill them. And you could make a little index of that, which is what we've done, and compare that index to all other primary care specialties, and psychiatry is way the main outlier in that kind of a thing. So the challenge is we have too few providers, clustered in too few locations, long waiting lists. I don't know how it is in some of these other countries, but I mean, I'm a psychiatrist. I have connections. If I try to get a friend of mine's adolescent in to see somebody, I'm often told, yeah, we can see them in 5 months. I mean, 5 months from now is just not good enough. And then where do they go? Emergency rooms and all the wrong places. Bottlenecks of services, over-reliance on emergency and crisis services. In the future, the demand is likely to increase, the supply is likely to decrease. So what do we do? And this is why I find this interesting, because I think we do need to do things differently, and I think that's a good thing, because I'm not too crazy about the way we do things right now. I don't think there's an easy one solution to this. What I do know is that advertising, help wanted, recruiters, doesn't work. I don't think that's the solution. Warm bodies with prescription pads, not going to work. What we need to have a multifaceted approach that focuses future training, recruitment, and retention on strategies of development of this creative, adaptable, and most importantly, collaborative workforce. The era of a psychiatrist sitting in an office with someone who knocks on his or her door, no matter what kind of problem it is, I think that era is coming to an end. I actually think that era should come to an end. I don't think that we have the luxury of maintaining that kind of relationship. So pieces of the solution, there's been a lot of reliance on recruitment or retention strategies, which essentially don't tend to work. I could talk about why. In the US, at least, there's been a big increase in non-physician people who have prescribing capacity, including in the US, advanced registered nurse practitioners, physician's assistant, and very controversially in the US, psychologists. There are several states that have passed legislation giving psychologists the ability to prescribe medications, and that is a piece of the solution, although a controversial one. A lot of people are talking about the use of telemedicine, certainly in terms of the maldistribution of the workforce, and there's some potential there. Expanding the concept of what the workforce is to more seriously consider how can we best use natural supports like family members who often do bear the burden of caring for the most seriously mentally ill but often can't get reimbursed for that. So, and the use of care coordinators that don't necessarily have to be professionals. I think the single biggest change is going to be in integrated and collaborative care models, and I'll talk just a little bit about that. I don't know how much time we have, but I'm guessing you want me to stay within 20 minutes or so. Does that sound right? Okay. This is just I won't go into detail, but there was an effort to enhance recruitment and retention strategies through extra grants. Basically, it didn't work. That's all I'll say about that. It's a failed effort. Okay. Non-physician providers. We've had some good success with this. We started, I don't know if you guys even have physician's assistants in other countries. Is that a thing in Canada, physician's assistants? It's a field that popped up in the United States, I think about 30 years ago as a part of the workforce problem. And it's actually been helpful. And basically we started a little program to train these physician's assistants specifically in psychiatry over. They have a 2-year training in general, and then we did a post-residency training, and it's been very helpful. And this is a nurse practitioners component, and we were able to get many more nurse practitioners to choose psychiatry simply by offering them a little financial incentive in their education. We built a physician's assistant fellowship program, which has been a little piece of the workforce, but I think has been helpful. We've had high quality, and again, that's just a little piece of it. Telepsychiatry, a lot of people have a lot of hopes about the use of telehealth. We've had lots of experience with it over the last 20 plus years. We know that in psychiatry, it yields good patient satisfaction, good clinical outcomes, and we've been waiting in the US for the tipping point for this for a while. Every year it seems like, is this the year that telemedicine is really going to take off? And so far it hasn't tipped. And I think it's not the technology, that's easy and cheap. It's important to get the health record integrated into it, and that's coming along. It's not reimbursement strategies, that's coming along. Basically, it's still the workforce. I mean, if you have people who are filled up with person-to-person visits, they'd rather do those, and they don't have to sit in a telemedicine suite unless there's some compelling reason for them to sit in a telemedicine suite. So we have empty telemedicine suites all over the US without bodies to fill them. Telepsychiatry itself is not the answer. It's figuring out how to exploit that technology and build it into more efficient practice models and then incentivize those kinds of practice models. This is a case example. This is one of the guys that we trained as a physician assistant, and he's very good. He went into one of the most underserved areas in the state. He had nobody to supervise him because physician's assistants have to work with a doctor. There was no psychiatrist anywhere near him. And we used telemedicine to provide that supervision. So that's an example of using telemedicine in a way that makes sense. Expanding concepts of the workforce. If any of you are interested in workforce issues, I would refer you to a wonderful document created by a group called the Annapolis Coalition that works simply on behavioral health workforce issues. And they have created a lovely summary of good strategies to deal with the workforce. And one of their strategies is really thinking outside the box on what the mental health workforce can and should look like, and include non-professionals as well as professionals. I basically think that this is the future. I think that we're going to be moving more and more toward meaningful integrated care models where psychiatrists and other mental health professionals, psychologists and others, are going to be parts of collaborative care teams, including primary care doctors, and that mental health care is going to be more meaningfully integrated into whole health care. That's going to require a very significant change in funding and a significant change in training. But I think that's really the future. There are many different models. People are now thinking actively in terms of how to incentivize primary care providers and how to pay for this to happen. In the U.S., I mean, basically what happens is what we do is what we get paid for, right? So if we can't, however we get our funding mechanisms in place, that's what's going to determine behavior of professionals. There's been a lot of progress in this just over the last few years. And I got to tell you, in the U.S., we have a fee-for-service funding model. I never believed that I would live to see a meaningful change in that in the U.S., where instead of getting paid to see a patient or do a procedure, we actually get paid based on the outcomes from a population health perspective. So this health system is going to take care of this population, and we're going to measure certain things, and we're going to incentivize how well you take care of that population. Once we start, and we're actually moving toward that fee for outcomes much faster than I would have ever imagined. I think there's reason to be optimistic. This has huge training implications. Right now we're still training our at least psychiatric providers in a model that is very 20th century. If I'm right, then the skill set that psychiatrists in the later 21st century are going to need and the way they're going to operate is going to look a lot different than the skill set that they had 20 plus years ago. And we're just now starting to recognize that, and only very innovative programs are meaningfully integrating psychiatry and the mental health workforce into the overall training of health professionals. So the future, at least in the U.S., is very clearly we expect a growing increase in demand for psychiatric services, and again, that's another lecture as to what is driving that increase. We expect the number of psychiatrists to decrease over the next few decades. If we're able to meet this need, we must work differently, and psychiatrists need to be at the table, proactively developing their new job descriptions. I would suggest that all of the subspecialties and different disciplines need to be at the table to figure out what role makes the most sense in this overall mental health workforce. And this is the board of our organization of the American Association of Community Psychiatrists as of last year. We also have a journal called the Community Mental Health Journal. We're very interested in international submissions, so feel free to send us your papers, and that's it. I'm happy to entertain any questions or comments. Yes?
You talked about the fee for outcomes.
Yeah.
How are they determined?
Yeah.
I mean, if you have a patient population, I know some doctors in Germany have that may be highly suicidal. You count how many die or not. I mean, how do you give them the money? You know, for that?
Yeah, I mean, it's a lot easier if you're dealing with, say, diabetes or hypertension, and you can measure hemoglobin A1C levels or blood pressure levels. But you can look at things like, you can look at readmissions to hospital, you can look at emergency use services, you can look at employment rates, you can look at patient satisfaction. One of the things that's actively in process right now is determining what the metrics are going to look like, and it's hard, and it's messy, and it's going to stumble for a while.
And I'm wondering if that kind of metrics or whatever it is will start driving how psychiatrists do their business. That's, I think, it's good to be outcome oriented, but if the outcomes are defined fairly
right.
narrowly, then they're
That's
going to
right.
say, okay, who cares if
And what gets measured is what gets attended to. So you're
Exactly.
absolutely right. So, and that's very important, because what I used to think my job was as a psychiatrist, if you asked me what my job was 10 years ago, I thought my job was to decrease symptom burden in patients. My population of interest is schizophrenia. I thought my job was to get them having less hallucinations, less delusions, less depression. That's what I measured. Today, what I believe is my job is stable housing, a decent job, a decent relationship, recovery-oriented outcomes, and that's what I'm attending to. So I think you're absolutely right that it's pretty important to get those metrics right in terms of driving what it is that's actually going to happen in the clinical interaction.
Thank you.
So, thank you. Thank you very much.